All right, so we'll take the questions in the end later on, and I would request the participants, if they have any questions, to write down on the papers that are provided, and then we can ask those questions after the presentation. For our next talk, we have Dr. Haseeb. Dr. Haseeb Zia is a hepatobiliary transplant surgeon in Islamabad, Shifa International. He's a leading transplant surgeon. He's got a number of publications. He's a very senior surgeon as well. But he's got a very important topic and a very interesting topic, which is regulatory and ethical aspects of liver transplant in Pakistan, which takes me back to a patient of mine just about 4 months ago who had alcoholic liver disease. He was a landlord. And when I asked him, okay, do you have a family pedigree? And then he told me that he had no donors in the family, but his donor will be arranged. And I said, how will the donor be arranged? He said he has a lot of workers under him, and they are actually his caste, so they are linked to his family and he can donate. So there are a lot of issues of organ trafficking and regulations. So without further delay, I would like to request Dr. Haseeb to take on the podium. Thank you.
Bismillahirrahmanirrahim. Thank you, PSH, for inviting me for initially I thought a rather boring subject, but as I looked into the subject, I actually kind of liked it. It's quite interesting, and there are things we do on a regular basis in our clinics. We meet people, we meet donors, and as a subject, when you look at this ethical part of donation and the rest of the things, so it starts to make more sense. So I can tell you at the very outset, it's a long, never-ending debate. Ethics, you can never finish. It cannot close as a subject. It's an open-ended sort of situation. And the other thing I can tell you is that you will have more questions at the end of this talk than the answers. So that's how ethics are. Okay, a lot of research has been done. If you look at this slide, more than 1,600 articles have been written on the subject from 60s to 2022, and more so on living donor liver transplant. And there is a reason for it. So when you look at the ethical side and the scope of this problem, if you look at the deceased donor liver transplant, the whole ethics revolve around fair organ allocation. And if you look at living donor liver transplant, in which we are interested, it's all about donor safety. So these are the two areas which actually take most of the attention when it comes to ethics. We have to go back to the history. It all starts in the United States. Back in the day, 1960s, no criteria for brain death, no system for organ allocation, till they passed a couple of legislations and a couple of acts. The Uniform Anatomical Gift Act, the Fair Organ Allocation Act, the OPOs, 1977 UNOS, OPTN, 1978 the Uniform Brain Death Act, etc. These were all the pathways which led to a fair organ allocation. And obviously it all starts with a fair, there's a supply and demand gap, has always been there. So more and more people need transplants, there are less and less organs, so there has to be an ethical way to fairly allocate these organs. Again, timelines. I think liver allocation used to be on a point system in the US, depended on waiting times and the patient location. And then came CTP score post 1997. We all know, we all use CTP score in offering liver transplants. And then obviously MELD and MELD sodium, they were incorporated by the UNOS into their allocation system. But the main problem remains that of shortage of organs. And sometimes this shortage makes you do things and bring new strategies. And we all know gradually these strategies have come into play. So the shortage of organ has remained the main problem. So how to expand the donor pool? Obviously, you need more and more donors, organs and donors eventually. So there was development of split liver transplantation. You could use one liver for two organs and could serve two patients. Then DCD donors, obviously this added a little bit. And finally the use of the living donors. And that's where the Eastern and the Asian side sort of comes in. So all these three parameters have been to increase the donor pool. And why you need to increase the donor pool? Because you had shortage of organs. So we have to look at the LDLT, a little bit of history. The first successful transplant was in '89, the living donor, and then this became the buzzword. Everybody wanted to do living donors. Till a time came that in United States, Mount Sinai, New York, 2002, a living donor, he expired and he died. Okay, this brought a lot of debate all over the US. Obviously, it was such a big thing, and if I tell you frankly, when you look at the literature of the time, you will find that actually living donor was kind of a bit unethical. It was sort of labeled as unethical type of a transplant. And actually, they were stopped to perform living donor liver transplants for a good 2-3 years before the inquiry and the committees decided on certain things. They looked into the surgical side of things, the medical side of things, but they mainly looked at the ethical sides of things. And obviously the concept of donor advocacy also started from there. And ever since 2002, living donor liver transplants have finally now getting a little bit flourished in the United States, because it was a bit of a unethical proposition. In the meantime, the Asian countries were obviously taking this on. So people did incorporate LDLTs into DDLT systems, and that they had a couple of good reasons for that. The low MELD score patients could not get on top of the queue. So there was a role of LDLT. Patients with cholestatic liver diseases, encephalopathy, refractory ascites, HCC outside standard criteria, patients in the regions where there were long waiting lists, and obviously the inflexible sobriety rules with the DDLT setup pushed the transplant programs to get into living donor liver transplant. So this was like a merger. So LDLT slowly expanded. It started with just first degree genetically related donors, obviously then legally related like spouses, non-biological donors eventually, emotionally related friends, strangers. The strangers are the true altruistic donors. And then once the systems and the process was streamlined, the surgical results were good, the living donor program started using older and maybe marginal donors, so to say. So what is the big question around the ethicality of a living donor? Is it morally right and ethically acceptable to use a healthy living donor for the sole purpose of providing an organ for another person? This is the whole debate. And time and again this debate comes. And on the whole, in the last 2-3 decades, the transplant community, the medical community has answered this question in a yes. It's a positive, it's affirmative. But this remains the question. As I said earlier, after this talk, I think we'll have more questions than the answers. So let's try and look into this subject little bit deeper. So the ethical dilemma in LDLT is, in the center is the problem that there's a sick patient. The patient wants to get transplanted because he wants to live. There's society. Obviously, they want this patient to be alive. There's a surgeon, physicians, the surgical team, the hospital. They benefit hugely financially and in repo. So all on my left side are the factors who want to proceed to this transplant, and there is a single person who's the donor, who has the liver. So he is on one side, and the rest of the parties are on the other side. And so it is a real ethical dilemma that you want to inflict harm and pain to this person who has no disease of his own. He's just come forward for a good cause. So somebody needs to make those ethical sort of decisions and restrict and make some boundaries in order to use his liver. So this is that basic debate. So we have to go back to, again, a little bit of the basics. These are the principles of medical ethics in LDLT. The first, so we are going to stay focused mostly on donor safety, living donor, and the ethics around it. The first principle is autonomy. So again, a question: does donors have enough information about the circumstances of their living donation, and do they provide adequate informed consent? This is the most burning question. And how can we provide adequate details, etc. So let's talk a little bit about informed consent. It has a lot of components. It was originally started to prevent harm and to safeguard the interest of the person who signs the consent. So the components are, if this individual, is this donor competent? Is he competent to decide? Obviously, it's a subjective sort of a feeling. I can consider somebody very competent to decide about his fate or his surgery, and another person can differ. So we need skilled psychologists for that. The second point is very important for me: disclosures. What do, as surgeons, what do we tell, or as physicians, what do we tell our patient? How much do we disclose? Do we describe the operation? Do we exactly tell them the risks? We all know for a major hepatectomy carries a lot of risks. And do we really openly tell them about death? A lot of people criticize me. Oh, you mentioned death. You don't have to mention death. As I said, that's the most important thing. That's what I'm afraid of. We all know. I like a small point. I like something about Pakistan. When I ask these potential donors, what do you do? They say nothing. More than 70% of my donors, they say we do nothing. So I like that part, because there are no major financial implications, because they were not doing anything before donation and they're not going to do anything after donation. That's, in an agricultural society, that's kind of a big thing. So we have to discuss job, we have to discuss the success in the recipient. We have to tell them what is sort of primary non-function. We need to tell them alternate treatments. If you continue to say transplant, 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 they will eventually go that way. But if you tell them there is another option, maybe TACE or resection, they might think about it. And a very big fundamental right is they should be able to withdraw any time before donation. This is very important. So anyway, competence, disclosure, understanding, freedom to choose, obviously, and reaching a certain decision. This is all in the informed consent. Again, one of the bigger principles is non-maleficence. Do no harm. Now, I am the surgeon who makes this big cut and actually voluntarily harms them. And I have to follow this ethics of not harming them. That's the basic dilemma. So how do we honor the principle, do no harm? And let me tell you, this is what we wrote recently at Shifa International, and we looked at we do harm the patients when we're taking a right lobe or the left lobe of the liver. And we looked at the textbook outcomes amongst our voluntary donors. And as Shafa International and as the Pioneer Group, we take a lot of pride in our donor results and no mortality and very minimum morbidity. But when we really dwelled deep into it and looked at textbook outcomes, this is a new term getting coined regularly, and we found out that we just had 70% of our donors had textbook outcome, and there was a 30% gap there. So where we used to think we are as good as 90-95%, we were actually 70%, and we have to presume that we did a good job anyway. So this is actually one of the first papers in the world, I think, has been written on this subject about voluntary living donors. So how can we not do harm? So that's again a question and a food for thought. So, and then another principle is beneficence, doing good. Obviously, we have to look at the donor motives, etc., and the recipient outcomes, etc. So we looked further into a little bit of types of donors. So a true altruistic donor is the one who doesn't even want his name to be known to the recipient. And then there is an egoistic donor. He's more interested in the relationship with the recipient. He's not interested in the outcome. He's not interested in the process. I personally think most of our donors in Pakistan are egoistic donors. And then obviously there is a maybe pathological donor who's a narcissistic donor who just wants attention. So another issue is what is in it for the family, and how are they pursuing this donor? Are they just encouraging him? Are they emotionally coercing him? So there is a bit of a difference between a coercive situation and coercion. Anyway, well, let's not go into that much of a detail. Coming to legislation in Pakistan, Human Organ and Tissue Act 2010. This is what sort of guides us. I must praise the government of Pakistan eventually to reach this point where they made this act. It just defines all the parameters, essential terminologies, legal boundaries. How do you recognize a certain center, institute? It defines punishments for illegal use of human organs and defines the role of the evaluation committee and monitoring authority and so on. So this is what mostly guides us. Not much here to say, but they're doing a decent job. Legislation became provincial. Punjab Hota came into being in 2012. What I have been told, I wish people from Punjab could further elaborate. So they are promoting, so to say, organ donation. They have a website. You can go there, register yourself as a donor, etc. And if you look at this is from the internet, P-HOTA we call it, website facilitates voluntary deceased and living donor donation through online form. One subject we left was donor advocacy. It's a standard practice, but it usually takes an episode, a big vakya, for donor advocacy to become real. It happened in our case as well. Independent donor advocate are the people who just safeguard the donors, simply. They support the donor. And their main purpose is to ensure that the donor understands the informed consent. That's where they are. They're not there to guide, they're not there to do this or that, but they're just making sure the person has read the consent properly and he understands actually in the true letter and spirit. So we have who can be a donor? Anyone can be a donor advocate. We have 5 of independent donor advocates at Shafa. They are not related to the transplant program. They are independent doctors. They have no sort of connection to us. And they do reject donors, and we have to accept it. And we have given them this sort of authority, and not authority, but sort of value, that we don't even question them if they reject a donor. And mind you, that our donors go to the donor advocate almost at the end because of the way the process is streamlined. And even if still they reject a donor, we will not even say a word. This is the form of independent donor advocate. He has to sign it. He reads each. He takes good 30-40 minutes with the donors. Coming to a couple of, say, loose recommendations. Preoperatively, recipient and donor, living donor teams, evaluation teams should be ideally separate. We are a very different society where 6-7 people would come into your office and they're all listening to each other. You're talking about the recipient, the donor will be listening, you're talking about his donation, his brother would be listening, so you need to separate them as much as possible, especially when the time of accepting the donor comes, or making the talk with him. Committees need to be there to ensure donor safety. Obviously, donor advocate is one and the same thing. Multiple checks. You have to have multiple checks at different levels. Can't go into detail. And whenever you are in doubt, this happens every 2-3 months in my office, and obviously other physicians and surgeons go through the same. Whenever you are in doubt, anything, just favor the donor. That is the general principle, at least I have learned over the past 10 odd years. Again, donation in special situations. Acute liver failure is one of the situations where time is the enemy. We have developed a separate pathway for ALF now, and we have transplanted good 10-12 patients and with very good results. And our aim is to transplant within 24 hours. Once those 24 hours are done, it's 3 a.m. or midnight, we start. We don't lose the night, or we don't lose this or that. So we talk about it some other time. So not enough time for the donors to think, and I think somewhat emotionally coerced they must be. It's such an alarming situation, and you can't leave gaps. Again, poor grade ACLF and HCC beyond standard criteria. You need to tell these donors the outcomes, the potential outcomes. Again, special social situations. Whenever you look at a young woman brought in as a donor, recent marriage, always get alerted. If you look at a bit of a social dichotomy between potential donor and the recipient, again, spouses are usually forced here and there. They can be forced, let me say. So conduct separate interviews and have multiple sessions. The way forward, this was a bill which was, I think, 2016, and it was trying for a compensation of 600,000 rupees for a potential or a donor. And I didn't really get the time to go into the details of this bill because it needs certain other skills. And they were also trying for other patients of foreign Muslim countries to actually come for transplantation to Pakistan. It's like a sort of a tourism, and they even specified 5 patients per month. So this is not the way forward. This was never passed, so it's not there. So I really don't know how to conclude this talk. I think the answer lies in this quote. Ethics is knowing the difference between what you have a right to do and what is right to do. So that's where everybody has to draw that boundary. May it be the physician, the surgeon, the anesthetist, whosoever is in this business of transplantation. What you can do and what you must do, there has a very fine line, and this is a bit of an individual thing. So thank you very much.
Thank you. Thank you very much. The right thing to do and what is our right to do. That is a very good saying, definitely. I think as physicians, as doctors, we must be patients' advocates, all of us. And it should, at least when I do my clinics, it takes me around 30 minutes to just do the transplant counseling, which is a very difficult thing for a busy gastroenterologist, hepatologist, or surgeon to do. With this, I thank you very much. This was a very interesting presentation, definitely away from the usual hepatobiliary surgery that Dr. Haseeb does. So now the podium is open for questions. We've got a few questions. We've got a question from Dr. Shams Zahri, and the question says that should we screen our patients who are not willing for transplant for HCC? I know the answer, of course. Definitely, if a patient is not willing for the transplant, still he might have HCC, and there are other reasons and there are other therapies that he can go. But if Dr. Shams would like to say anything, I'd add it to that. Yes, there are other local regional therapies that can be actually curative. Dr. Najam, for you there is a question. I would request कि mic अगर आप वहाँ जाके Dr. Najam को दे दें. There is a male predominance in liver transplant recipients. Does this mean we have HCV infection more frequently in males in Pakistan? And what are the views on this mismatch? What happens in the West?
Thank you. I think there is data that shows that gender is a risk factor for various etiological diagnoses like HCV, for example, or hepatitis B. Bilal would be more from the international data, but I think we see this predominant male population in almost every topic and publication you see, except maybe gynae-related issues in Pakistan. So I don't know whether this is access issue or whether this is a true predilection of the male population to these diseases. I don't know the epidemiology of this.
So maybe from the West we can have a few comments as well. There is a lot of gender equity over there.
But if you look at the Sindh data, I think you can see that I think this is an access issue, definitely. And I think this is a reflection of the society as well. And I think as you see from the pre-DA's era when I showed, there's a gradual increase in the number of female patients coming for transplantation. So there is definitely an improvement. And I think it's an access issue as well.
Can I ask a question from Dr. Najam as well, please? Dr. Najam. So you mentioned about a slide about the 30-year span for hepatitis C, a very, very good slide of it. And obviously hepatitis B occurs in childhood, whereas hepatitis C is usually contracted later on. Do you think the fact that there was a difference between group 1 and group 3 is more related to the fact that in group 3 the patients were of a younger age rather than the DAAs causing the difference? Because it will take some time for the DAAs to reflect that difference.
I think it's not very simple. The reason for that is if you look at the data from Sindh, you see that 39% was their mean age with decompensated liver disease going for transplantation. And their predominant etiology was actually hepatitis B. And I think that's amazing to see that you see people reaching to that, and that would be a reflection of the hepatitis B going into cirrhosis and then they're going for liver transplantation early compared to the HCV etiology. So that is one thing, observation from that group 3 and group 1 difference from the Gumber data and for the rest of the period. But I mean, looking at the, there must be other factors. Like we see like alcohol, we see HIV, we have other factors that can accelerate that fibrosis process. We normally don't see those factors very prevalent in our society, and I think there must be a genetic predisposition of some sort, because our patient, compared to the West, where it takes 30 years for people to decompensate, we see like patient in 30 and 25 years with HCV going into decompensation and with HCC. So I'm sure there are unknown other factors that we don't know. And I think, in my opinion, we discussed that with Dr. Saleh a long time ago, that I think it's a genetic play. And I'm sure that if we do look deeply into the the causes and some research, I think that would be probably some unknown factors. Malnutrition, fatty liver, we don't know. So many other factors can really contribute and add to that, accelerate that fibrosis process. So I think etiology, definitely acquisition. But I mean, look at the transmission of hepatitis B and C, the mode of transmission are the same. So you would expect that somebody who has a high rate of hepatitis B, you look at the chronicity, 80% of HCV after acquiring the HCV will go into chronic phase compared to hepatitis B. So the mode of transmission, needles and unsafe practices are very prevalent. And you would expect both virus exposure to the same population. But we see that there is a big difference between the prevalence of these HCV and hepatitis B in Pakistan, 5% and 2%. So there are factors which I really can't explain.
Thank you very much, Dr. Najam. And with this, I would like to thank our speakers. I would like our chairs to have comments, and if there are any questions, we can ask those questions.
Assalamu alaikum. I will like to ask Dr. Bilal about it's a very kind of hot area of expansion of the criterias for the transplant, and we've been kind of hearing it for over a decade on this topic. We, in our center at Sheikh Zayed, we try to kind of go a little bit further than in the expansion criteria, but results were not that encouraging. So how do you see your center, and what is your experience regarding the expansion of the criteria?
You know, again, this is always a struggle. The question is what is the outcome you're looking for, right? And again, in the US, we're looking for 70–80% survival. The recurrence is the most common cause of death in these patients. You know, that's where it's not about the size, it's what the response to the treatment and tumor marker or biomarkers. We are using more and more. It's a combination of actually beside alpha fetoprotein. Now we are using DCP and L3 fraction, which has been shown that they are actually more, you know, gives a more response to the treatment, and also the criteria with the recurrence post-transplant. So we had a different also protocol, which is basically called all-comers protocol. Similarly, but those patients also need to be downstage. I think that's the key. And we look at the biology of the tumor before going forward with the transplant. We have an average wait time for a long period of time. And then, so when they wait for 6 months, we automatically, like, you know, kind of patients who have a biologically, the difference is if you have a living donor, when you're going to move forward. So I think that you have to be selected. And in those patients, again, if they have Child's A, you know, those are fine. But we have shown that if you have Child B and C, they cannot be downstage, they can't get any treatment. So we exclude them right away. So in that percentage of patient, they are selected patient, we able to reach to the transplant, and we had good responses in that. So I think the ideal, finding that candidate and finding those markers will be very important. And so there are patients we have done transplant which were outside UCSF, and they were what we call all-comers protocol.
Before we conclude and thank our speaker, I would say, sorry, Dr. Najam.
Doctor, I just wanted to just mention, we published 1,000 HCC data from Shifa, if you remember, and we publish as a decision-making tool. We don't use any prognostic scores or, you know, traditionally 17 different types. We have our own decision-making tool where we incorporate different prognostic variables and size, vascular invasion, etc. And I think there was a very small percentage of patients who were downstageable actually in our cohort. And that's why, what method of downstaging would you use? How much is the quantity? I think not very big number.
I must agree with Dr. Najam that when we questioned him a lot of time, we also saw that Barcelona Liver Clinic followed and incorporated those components very late after 2016 and then 18 and always, but we thought of it in 2013 and we presented that. Now, I would just add to Dr. Haseeb's, I would say, the talk on the ethics, that the donor advocacy is there, but I think our donor advocacy probably stops somewhere around a month or 3 months after that. And it's a reminder to myself and to everybody in this room as well from this country that probably we need to look and to follow these donors beyond months and see where they are and help them, because we have seen and we have heard few things which are probably thought-provoking and at times disturbing. So we need to work, probably these donor advocates, while they're selecting these patients, should also be following in a true sense later on more rather than during that time, and of course in that time as well. So if there are no questions or comments from the 3 other chairs who are online with us, then
We can request, we've got Dr. Faisal Dar and Dr.
yeah,
Abu
we
Bakr
are
Hafiz.
they're there, so if they can comment.
So we can ask them for their comments online. Online. Dr. Faisal Dar and Dr. Abu Bakr Hafiz. Both of them are online. Dr.
You would
Faisal,
like
can
to-
you hear us?
उनके माइक्स को अनम्यूट कर दें.
Can you hear me?
Yes, Dr. Faisal, we can hear you.
Yeah, thank you very much. I thoroughly enjoyed the session. I think it was nicely related talks to each other, but I was expecting Haseeb to do more justice at the end. I think it is a difficult topic. He nicely covered most of the aspects, but the more focus was on the donor safety. Although it is one of the major part of a transplantation, but considering the previous two talks, I think talking about other ethical aspect of transplantation, like hepatitis C, recompensating after antiviral treatment, when to transplant, patient with big frailty scores and too sick for transplantation, and considering Sham's talk about HCC beyond certain criteria with a high rate of recurrence, would have been interesting if included as a part of the ethical debate in this session. But otherwise, I think it was a beautiful session and I thoroughly enjoyed and congratulate all the speakers.
Thank you, Dr. Faisal. So, thank you people for sitting and listening patiently. We move on with this to our state-of-the-art lectures, and we've got...
Can I have a few questions, please? I mean, this is Abu Bakr, before you move on.
Yes, sure, Dr. Abu Bakr.
Okay, thank you very much. So, this is Abu Bakr. I'm a liver transplant surgeon at Shifa. So, I mean, the talks were great and they were interesting, but then again, there are certain questions that I have and I could not stop myself from kind of, interrupting you guys. So the first talk by Dr. Najam, it was great as always, and he presented the trends about different etiologies of liver failure and transplants that we are doing in these patients. But basically my question was that the way the data was presented, so basically you started from Shifa, then Qaid-e-Azam, and then PKLI. So I understand that there was a temporal association of this data, but then you were also changing centers, the type of patients who were coming to these centers, whether the transplants were funded or they were sponsored by the government. Do you think that also has to have a bearing on the types of patients that ultimately undergo transplant? The reason I'm saying that is because out of, I would say about 1,000 transplants, that's the data I have, still 795 patients who were transplanted had HCV. So this is almost 80%. And similarly, 175 patients had HBV. So this is around 17 to 18%. So, I mean, as far as Shifa is concerned, I mean, maybe the trends are changing, but not to the extent that probably appears to be from your presentation. So that would be a question from you. And from Dr. Shams Zehri, again, a very great talk. My only question is about the extended criteria in terms of alpha-fetoprotein, more than 1,000. I mean, generally we know that when you have an AFP of more than 1,000, the recurrence rate is very high. It has been shown again and again. But I also understand that it is not a no-go area and we need to expand. So how do you decide? I mean, I know you have talked about the PET scan, but do you think PET scan alone is enough? My question would be, did you consider them for downstaging, or those patients were not downstageable? So that's from you. And as far as Dr. Haseeb is concerned, it was a great talk, but I lost the connection. So I mean, I could not hear it completely, but Professor have raised that I think some other points, they would have made this really interesting, debatable discussion. Thank you very much.
Thank you, Dr. Haseeb. So Dr. Najam is with the mic.
I think it's always very difficult to defend such data. And I think I really explained in the beginning how I collected my data. But my main concept was that the catchment population was nationally representative in all centers. If you look at the percentages from different provinces, I thought that we were the largest group in Shifa. When we moved to Qaid-e-Azam, we still had a substantial number in the post-DAS era, and I think we were the largest group and the population which we represented was in the data was quite representative of the whole nation. And then the PKLI being in the center is also probably showing national trends in that data. The only regional variation was from Gumbert, and I think we all know that hepatitis B is more prevalent in that area. And I think that data very beautifully showed that while the decompensated cirrhosis HCV was less, but the HCC, HCV was the predominant etiology. So in my opinion, I think this can never be conclusive because there's a 220 million population with 11 million HCV. We don't expect a lot of reduction, but I think there are definitely trends from this data at least, which shows that the DAAs are working in some way, in my opinion.
Yes, Dr. Shams.
Thank you, Dr. Abu Bakr, for your kind words. Actually, whenever in a HCC patient, we always give priority to the patients that they should be downstage before a transplant. Even the patients who are within Milan criteria, we have, because our waiting time is very high, so definitely we ask them to go for the TACE as a bridging treatment. So definitely if they are beyond any extended criteria, we always advise them to go for the downstaging with the help of loco-regional therapy. But the scenario which I explained over here, these two patients, their bilirubin were more than 4. So definitely we couldn't do any other, they don't have any other, they did not have any other option. That's why we decided, we did the PET CT, and what protocols we are following, we usually do the CT scan, then if alpha fetoprotein is more than 1000, we go for the PET CT scan, and plus as well as the liver functions, they are also make a very important role. If the liver functions are very bad, then we decide with in our MDT that we should proceed for the liver transplant even in this patient. So it is still too early to say that what will be the outcome of these patients, but from the data from the international studies, we see that if the PET CT, on the basis of PET CT, if the tumor is PET avid, but even if it is not more than 5, they have excellent result. Some studies say that even they have 5-year disease-free survival of about 55 to 60%.
मैं उसको कहें कि वो जिसके भी हमने more than 1000 किए, आप माइक लेके कहें कि उनका प्राइमरी ट्यूमर इतना था ही नहीं कि जिसको डाउन स्टेज किया जाता. आप साथ ही बैठे माइक पकड़ के बोलें.
I'm sorry for that. I think there was a unmute. The mic was not mute. So thank you, Dr. Shams. And with this, I would like to move on to our next session. And we've got Dr. Israrul Haq, who will come and moderate our next session, which is state-of-the-art lectures. Thank you, the chairs as well.
Hello. बस वो अभी किया उसने.